Welcome everyone. In this video we shall be talking about hereditary spherocytosis and discuss all the questions related to it. So moving on to the first question. Which of the following membrane proteins is most commonly mutated in hereditary spherocytosis? Right. So we have the RBC membrane over here. This is our band 3 protein. This is our band 3 protein, which is nothing but our anion exchanger 1. Okay. Then we have this. This is our ankyrin protein. These two represents the alpha and beta chains of spectrin, and D is our actin. So now remember the sequence that the most commonly affected one is ankyrin, and after ankyrin we have band 3, then we have spectrin. In spectrin, beta is more commonly affected than alpha, and then we have protein 4.2, this protein. Okay. So our answer should be B from over here, because ankyrin is the most common one to get mutated. Okay. Moving on to the next question. Excuse me. Now, consequences of membrane protein defects in hereditary spherocytosis. Now, what happens in hereditary spherocytosis? In hereditary spherocytosis, the membrane becomes unstable, right? The RBC membrane becomes unstable. Okay? As a result of which it does not allow the RBC to get deformed in the capillary beds. It does not allow deformity in capillary beds, right? So there is failure to passage, there is failure of passage of RBCs through capillary beds. Through capillary beds, the RBCs cannot pass, especially of the spleen, where they get destroyed, right? Now, what happens in the capillary beds? There is trimming of the membrane. Right? Trimming of the membrane of RBCs, and this results in conversion of this biconcave RBCs into a sphere, right? And this leads to loss of the biconcave shape, right? And finally formation of spherocytes. Okay. Let's now have a look at the options. Decreased deformability of the RBCs, that's a true statement. Loss of membrane surface without proportional loss of volume, that's a true statement. Actually, both volume and surface area decreases, but the decrease in surface area is much more than that of the volume, right? Osmotic fragility increases, that's also a true statement, right? This is directly dependent on this deformability, right? So A and C are linked. Next, the mean corpuscular hemoglobin concentration decreases. Now, this is a false statement. Why? Because your RBC converts from this to this. There is a decrease in volume, right? Although the decrease in volume is less than that of the surface area, but there is an absolute value of the volume decreases, right? But there is no significant change, decrease in hemoglobin, right? Your hemoglobin content remains the same, and the volume in which it is dissolved decreases, as a result of which the concentration should increase. So your MCHC increases in hereditary. Spherocytosis. It does not decrease. Okay. So our answer would be A, B and C. C should be our answer. Okay. This is an INI type question. Moving on to the next question. Which of the following triads best describes hereditary spherocytosis? Now remember it as a fact that hereditary spherocytosis present as a triad of anemia, and this anemia is due to extravascular hemolysis. Which occurs in spleen. Okay. Next we got jaundice, right? This is due to unconjugated hyperbilirubinemia. This is due to increased unconjugated bilirubin. What happens is that whenever there is destruction of RBCs, whenever there is hemolysis, there is release of hemoglobin, and this hemoglobin finally gets converted into bilirubin, right? And this bilirubin results in jaundice. And finally we have splenomegaly. Because the spleen is sequestering the spherocytes, right? So our answer over here would be A. Okay. Anemia, jaundice and splenomegaly. If we have a look into the other options, this hemoglobin urea is a marker of intravascular hemolysis. Okay. And this triad of hemoglobin urea, renal failure and anemia is seen in microangiopathic hemolytic anemia like HUS, right? If we have a look into the next option, pallor, lymphadenopathy and fever, this lymphadenopathy and fever suggests us of infection or lymphoma. And the final option of pancytopenia, hepatomegaly and infection, everything over here suggests of aplastic anemia. So our answer would be A. Okay. Moving on to the next question. A 14-year-old presents with pallor, mild jaundice and splenomegaly. Peripheral smear of the patient is shown below. The family history reveals similar illness in the father. Family history. What is the diagnosis? Excuse me. Over here we get the triad. Of hereditary spherocytosis. The peripheral smear over here shows us spherocytes. Spherocytes are present everywhere, and moreover we get the family history, similar illness in father, and we all know that hereditary spherocytosis is an inherited disease, right? It shows autosomal dominant inheritance pattern, right? So there are three things to suggest us that the diagnosis over here is hereditary spherocytosis. Okay. If we look into the other options, how to rule them out, autoimmune hemolytic anemia over here, yes, we do get spherocytes, but remember that there is no family history. There is no family history in autoimmune hemolytic anemia. Moreover, over here the Coombs test will be positive. Okay. Then G6PD deficiency over here in the peripheral smear, we would get the bite cells, or Heinz bodies, right? In paroxysmal nocturnal hemoglobinuria, it presents something. It does not present with this triad, right? It will present with hemoglobinuria. It would present with hemoglobinuria. There would be features of pancytopenia, right? The presentation would be completely different in PNH. Okay. Over here, that's why our answer would be hereditary spherocytosis. Okay. Moving on to the next question. Complications of hereditary spherocytosis include, right? Pigment stones, yes, this is a correct one. Right, there is increase in this is due to increased unconjugated bilirubin due to hemolysis. Okay. Aplastic crisis, yes, aplastic crisis is also seen in hereditary spherocytosis, and this is secondary to parvovirus B19 infection, right? Megaloblastic crisis. Now what happens due to increase in hemolysis, there will be a compensatory increase in erythropoiesis by our body. There will be compensatory increase in erythropoiesis. Right now, an erythropoiesis would result in increased folate consumption, increased folate utilization. There would be increased folate utilization, as a result of which we would get a secondary folate deficiency, and this secondary folate deficiency would trigger a megaloblastic crisis. Right, over here we would get the megaloblastic features, right? So hereditary spherocytosis can trigger a megaloblastic crisis due to folate utilization. Next, iron overload due to hemolysis. No, that's a false statement, right? Over here in hereditary spherocytosis, the iron is recycled. The iron is recycled and utilized, right? We usually iron overload is due to excess blood transfusion, which is not required in hereditary spherocytosis. Okay. So option D is incorrect. Our answer would be B. Again, an INICET question. Okay. Moving on to the next question. Which of the following statements regarding osmotic fragility test is true? What happens in osmotic fragility test? Right, we insert or we place the RBCs. We place the RBCs into hypotonic fluid. Right. As a result of which water is now going to enter into the RBC because it is in hypotonic fluid. So when in a normal RBC, when the RBC is in its biconcave shape, now in a hypotonic solution, water enters and this RBC swells up into a sphere. Okay. But in a hereditary spherocytosis, when there is already a spherocyte, when there is no more space to expand, now when it is placed in a hypotonic solution and water enters, there would be rupture of the cell. Okay. Normally, the rupture of the cell, so this increases our osmotic fragility. We all know that 0.9% saline is isotonic. Right. Now, a normal RBC can tolerate up to a concentration of 0.3 3%, right? In a 0.3% saline, our RBCs will swell up to become a spear, big spear, but it will not rupture. But in hereditary spherocytosis, when the RBCs are placed, when the deformed RBCs are placed in 0.3% hypotonic solution, water is going to enter and can cause rupture of the cells. Okay? So now let's read the option. Hereditary spherocytosis shows decreased fragility. No, they show increased. Yes. B should be our answer. Hereditary spherocytosis shows a normal. No. Shows lysis only at 0.1%. No, it starts to show lysis from 0.3%. And remember a few important points. That thalassemia and sickle cell disease are the ones that can show decreased fragility. Okay. Moving on to the next question. Which of the following tests is given below is correctly matched with respect to hereditary spherocytosis? Osmotic fragility test, increased fragility. That's a true statement. We know this. Autohemolysis test, increased hemolysis corrected by glucose. That's also a true statement. What happens in autohemolysis test, right? The RBCs are kept for 48 hours, right? There is already a baseline defect in the RBC membrane. The RBC membrane is already unstable, right? Now we have kept it for 48 hours. There would be ATP depletion. This ATP depletion adds on to the instability, right? It increases instability of membrane and there would be rupture. Okay. But if you add ATP, but if you add glucose, now ATP will be replenished, ATP will be present, right? There will be presence of ATP. ATP depletion will be extremely slow over here. Although there is a baseline defect in RBC, but there is not an additional factor which is hitting the membrane again, right? So over here, the instability will be less. There would be less instability of membrane, right? Therefore, the rupture won't be seen, right, with the addition of glucose or maybe even corrected with glucose. Okay. Next option, Coombs test positive. That's a false statement, right? Coombs test positive is seen in autoimmune hemolytic anemia. Okay. EMA binding test. Now remember that EMA binding, EMA stands for EMA stands for eosin 5 malamide. Eosin 5 malamide test. Eosin 5 malamide binding test. This is the most sensitive test. And is considered confirmatory for hereditary spherocytosis. Okay. What happens? This binds to band 3. And since band 3 is defective, EMA binding decreases. Now one might argue that the most common mutation that occurs is ankyrin, but remember that this ankyrin, band 3, band 4.2, every protein forms a cytoskeletal complex. Now if any one of the entities are deformed over there, the whole complex gets disrupted. That's why your EMA binding will be decreased in any of the mutations. Okay, not only band 3. So this is also a correct one. So answer should be A, B and D. Again an INI type question. Okay. Moving on to the next question. Which lab findings are typically seen in hereditary spherocytosis? Increased MCHC, yes, we all know this, we have discussed that. Increased retic count, yes, due to hemolysis there would be increase in retic count. This is due to compensation. This is a compensatory increase, right? Release of the reticulocytes from your bone marrow. Coombs test negative, that's also a true statement. LDH decreases, no, that's a false statement. Over here there is increase in LDH because there is cellular rupture, there is hemolysis. Whenever there is hemolysis, LDH being an intracellular content will be released into your plasma. So over here answer should be A, B and C. Again a multiple answer question. Okay. Moving on to the next question. Spherocytes may be seen in hereditary spherocytosis. Of course we do get spherocytes in hereditary spherocytosis. Warm autoimmune hemolytic anemia, yes. Over here what happens, your macrophages partially phagocytose the RBCs, the immunoglobulin coated RBCs, they partially phagocytose the immunoglobulin coated RBCs. Okay. Clostridial sepsis, over here the toxin of the bacteria damages the membrane, RBC membrane, right, thereby adding to the instability. That's why we can get spherocyte formation. Burn injuries, there is direct injury. Whenever there is injury to the RBC membrane, whenever there is injury to the RBC membrane, there would be instability, and instability would result in trimming of the membrane in capillary bed, resulting in formation of spherocytes. That's why Over here all of them are correct. Okay. Moving on to the next question. A 15-year-old boy with known hereditary spherocytosis presents with sudden onset pallor, weakness and fatigue. Now lab test reveals severe anemia and a low retic count. He had a mild viral illness 1 week ago. Which of the following is the most likely cause of acute deterioration? Now over here we see there is low retic count. This low retic count suggests that it is not a hemolysis. It is not a hemolysis. Had there been hemolysis, an hemolytic crisis, there would have been an increase in reticulocyte count, right? Decreased retic count suggests that there is a decrease in bone marrow function. There is a decrease in bone marrow function. Moreover, we get this viral illness and these two things in setting of hereditary spherocytosis suggests of aplastic crisis, which is secondary to parvovirus. Which is secondary to parvovirus B19 infection. Okay. So answer would be A, aplastic crisis due to parvovirus B19. Let's have a look into the other options, how to rule them out. In hemolytic crisis, as discussed, there would be increase in retic count. Megaloblastic crisis due to folate deficiency. What happens over here? Yes, we would get a decrease in retic count. In megaloblastic crisis, we would get a decrease in retic count, but remember that megaloblastic crisis would never ever be an acute presentation. Over here there is an acute presentation of acute onset pallor, right? You won't get an acute presentation in megaloblastic crisis, and moreover we would get the other megaloblastic features as well. In sequestration crisis is quite rare in hereditary spherocytosis, but again in sequestration crisis there would be increase in retic count. There would be increase in retic count, right, and would be associated with splenomegaly, as well as pain, right? Okay, that's why it's not a sequestration crisis. Our answer would be aplastic crisis. Okay. Moving on to the next question. Now, indication for splenectomy. Remember that splenectomy is not routinely done. It's not a routine procedure to be done in hereditary spherocytosis. There are certain indication, of which moderate to severe anemia is an indication. Growth retardation is also an indication, because splenectomy in such patients can lead to improvement of growth. They improve growth in such children. Symptomatic splenomegaly is an indication of splenectomy, and pigment gallstones are also indication. Besides these four, right? Severe decrease in exercise tolerance, or like extramedullary hematopoietic tumors, hematopoietic tumors are also an indication for splenectomy. Just remember it, that it should be done beyond 6 years, after 6 years of age, in order to prevent infections, prevent the risk of infections. They should be done after 6 years of age. So over here as well, our answer would be D. Okay. Moving on to the next question. A 17-year-old with hereditary spherocytosis undergoes splenectomy. Which hematological changes expected to occur post splenectomy? Now what happens in a hereditary spherocytosis? We performed splenectomy. Now what happens? Spleen was responsible for destruction of the spherocytes. So there would be decreased destruction of spherocytes. This would result in decreased hemolysis, right? Okay. Let's have a look into the option. Disappearance of spherocytes. No, the spherocytes are formed in the capillary bed, right? Spleen is responsible for destruction of the cells, but they will be formed in any of the capillary bed, because in hereditary spherocytosis your membrane is defective. Whenever it passes through a capillary membrane, there will be trimming of the membranes, resulting in formation of spherocyte. Normalization of osmotic fragility. No, it does not cure the defect. Cure of molecular defect. No, this is also incorrect. Our answer. Decreased retic count. Now, whenever there is decrease in hemolysis, right, we all know that there is decrease in hemolysis. We all know that reticulocyte count is directly proportional to hemolysis if your bone marrow is functioning normally. So whenever there is decrease in hemolysis, there would be decrease in retic count. So our answer would be D. Okay. Moving on to the next question. A patient who underwent splenectomy for hereditary spherocytosis is found to have the following finding on peripheral smear. What do these inclusions represent? Now this is a Howell Jolly body and is seen post splenectomy. splenectomy, and it represents the nuclear remnants which were usually in a normal condition would have been sequestered by the spleen. So yes, it should be nuclear remnants normally removed by spleen. If we have a look into the other options, iron containing granules derived from mitochondria, this is parenchyma bodies. This is parenchyma bodies, right? This is also seen post splenectomy. Besides that, it can also be seen in myelodysplastic syndrome as well as lead poisoning, lead toxicity. Okay. Denatured hemoglobin precipitating into this is Heinz body. This is Heinz body, which is seen in G6PD deficiency and is triggered by an oxidative stress. Okay. And RNA remnants from incomplete maturation, right? These are basophilic stipplings. Right? These basophilic stipplings are seen in megaloblastic anemia. They can also be seen in myelodysplastic syndrome as well as lead poisoning or lead toxicity. Okay. So with this, we come to the end of our discussion on hereditary spherocytosis. Right? If you like this video, consider subscribing to my channel, and thank you for watching.